And we will, Dr. Mustafa Surti has joined, okay. So Walid, you can start recording.
Sure, go ahead.
Assalamu alaikum, everyone, and thanks for joining us today. Welcome to the 17th session of the HIV Awareness, Prevention and Education Project in Pakistan, designed and led by APPNA-MERIT HIV Committee. This project aims to reduce HIV stigma, increase HIV awareness, and increase knowledge about the disease among the healthcare providers in Pakistan using educational and research tools. Please note, this is a volunteer academic activity. Our main purpose is to open dialogue with key partners who are participating or responsible for implementing HIV care programs in Pakistan. We do not affiliate ourselves with any political party in Pakistan. All views expressed in these webinars are speakers' own views and do not reflect any institution. Our approach is forward-looking, and we are hoping to get constructive feedback from all our participants. Please write all your questions in the QA and question and answers box or even chat box. We will see if we have time at the end. We will try to answer as many questions as we can. Today's webinar style is a little bit different. Our team is going to interview Dr. Ayaz Qureshi, and then two of our experts from different fields will comment on HIV stigma and our communities in Pakistan. Our moderators today are Dr. Saima Abbas and Dr. Yusuf Sheikh. Dr. Saima Abbas is an infectious disease physician working in the USA and is the co-chair of the APPNA-MERIT HIV Committee. She graduated from Fatima Jinnah Medical College and completed her internal medicine residency and infectious diseases fellowship at University of Toledo, Ohio, USA. And Dr. Yusuf Sheikh is an assistant professor of medicine at University of Massachusetts Medical School, USA. He is the immediate past president of APPNA, which is a local chapter of APPNA. Dr. Yusuf Sheikh is a graduate of Dow Medical College and completed his residency training in internal medicine from University of Illinois in Chicago. Thank you, Dr. Abbas and Dr. Sheikh. So please take over.
Sure. Assalamu alaikum, everyone. So, as Dr. Gilani mentioned that this will be a different webinar. We will be talking about Dr. Qureshi article here. This will be a 90-minute webinar, and let's welcome our esteemed speaker, Dr. Qureshi. Let me tell you about him that Dr. Ayaz Qureshi is the senior lecturer in the medical anthropology at the University of Edinburgh, Scotland. He carried out ethnographic work on HIV/AIDS control in Pakistan and received his PhD in social anthropology from School of Oriental and African Studies, London. His research interests include sexual and reproductive health, NGOs, bureaucracy, healthcare systems, and neoliberalization and labor relations. He has published articles in the leading international journals, such as the Journal of Royal Anthropological Institute, Development and Change, Anthropology and Medicine, and Global Public Health. His monograph, AIDS in Pakistan, Bureaucracy, Public Goods, and NGOs, is the first full-length study of HIV/AIDS work in relation to government and NGOs. This book encourages readers to reconsider the orthodoxy of policies regarding public-private partnership by critiquing the resulting changes in the bureaucracy, civil society, and public goods. So one of his articles that we are discussing today was published back in August in the Journal of the Royal Anthropological Institute. So let's welcome Dr. Ayaz Qureshi. Dr. Qureshi, I will be starting with a couple of questions, and so first of all, tell us about your journey as the anthropologist and actually, what do you do?
Thank you very much, Dr. Yusuf. Thank you also to other colleagues, Dr. Fiza, Dr. Saima, for having me for this seminar. Really privileged to be speaking to you and other colleagues in Pakistan and across the world. It's a big privilege. Regarding my work as an anthropologist, so I'm a medical anthropologist by training. I did a PhD from SOAS, as you mentioned in the intro, back in 2012. The PhD was on Pakistan's HIV responses. So during that ethnographic work over 2 years, 18 months to 2 years that I was in Pakistan for ethnographic fieldwork on HIV policy around 2009 to 2011, I tried to understand as an anthropologist how the state, the government, the private sector, civil society, donors organizations, and people living with HIV and those who were at a greater risk of contracting HIV were responding to this epidemic in Pakistan. So this response, as many of you would know, had been scaled up in 2003 with the World Bank intervention with that project on enhanced HIV prevention and control program. But before that also, there had been efforts to prevent HIV and to provide support to people living with AIDS. So my PhD was about looking at responses from various quarters and trying to understand a bigger picture of how the country was responding to the epidemic. Why I did that is a different story. I was interested in infectious diseases before starting the PhD. I had done a master's in anthropology, which trains you to be an ethnographic field worker. So I had done some research on indigenous health-seeking behaviors in the past. And then after the master's, around 2002, I was part of a number of research projects in Pakistan as an enumerator, as someone who was in the field on behalf of different research institutions and agencies, collecting data from villages, from house to house visits, as part of teams, supervising teams sometimes, and sometimes also writing reports. So that is where I became interested in trying to understand where does all that research go? Where does all that data go that we collect? And how much of that data is part of the policies that are then formulated and implemented? And HIV was an obvious place to go for me because it was big at that time in what is now known as scale-up decade for HIV. Everyone was talking about HIV as this big problem that many countries were facing.
I mean, was there any specific reason to pursue HIV only? Because there are other endemic infections in Pakistan. We've been talking about TB, malaria, and Hep C in Pakistan for a long time too. So I'm just curious to know anything specific which attracted you to HIV research and prevention?
Yeah, I mean, nothing very specific except that the trajectory that I had, personal trajectory, took me there. So I did a project on men on the move, this famous project with colleagues from London School of Hygiene and Tropical Medicine and Dr. Arjman Faisal in Islamabad. So I was very much involved in that project. And during that project, we were talking about these young people in Lahore. We used to visit them, interview them in the evenings, migrant men who had very risky sexual behaviors in some cases. So those discussions, and also I was the field supervisor, so I was in discussions with my team also, trying to understand the link between infectious disease and sexual behavior So that led me there. HIV was obviously also being talked about big time at that time. And I was hoping to get a PhD scholarship from an institution, a university in the UK. HIV seemed to be the disease that would perhaps help me focus and also win some funding for a doctoral project. So that took me there. I mean, before starting this PhD, my experience was obviously limited. Experience of working with HIV positive people or organizations of HIV positive people. I didn't have much experience. I had worked with public health experts working on infectious disease, but not directly with HIV positive people or their organizations.
Sure. Now, can you please summarize the main findings of your research in this article that you published recently?
Okay, yeah. So the project was, as I said, about understanding the overall response towards HIV in Pakistan. And out of that project came many articles, including a monograph, which I published in 2018 with the title of AIDS in Pakistan, Public Good Bureaucracy and NGOs. So that's the broader frame within which I would locate this article that many of the colleagues on the call have read. So in that book, in the broader project, I am trying to look at these three specific areas. So as Pakistan responded to HIV, how did it impact the way bureaucracy works? And what did it entail in terms of the provision of public goods in Pakistan? And also my understanding from this ethnographic work of the nature and the working of NGOs. So that is the larger project in which I talk about bureaucracy, restructuring of the bureaucracy. I also talk about, at some length, about public-private partnership models and the difficulties that are often encountered but ignored when implementing public-private partnership programs. And in the book, I also talk about civil society in the sense of activism, of grassroots individuals who are politically engaged and who are community-based, like HIV positive individuals that I have written about in the book. So this particular article is more of an offshoot of one of the themes, which is the NGOs. So trying to understand the working of NGOs in this landscape of HIV prevention and control. That is what this article tries to do. And in this article, I work with the notion of stigma. So stigma, as you know, is a very important concept, a very important reality in people's lives, not only those who live with HIV and AIDS or who are at risk of contracting HIV AIDS, but otherwise also the many forms of stigma that people experience, especially those who are at the margins of society, social margins, political margins, ethnic margins, sometimes all kind of minorities. So stigma, it's a big concern for anthropologists. And I take stigma as a concept and try to understand how stigma operates in this universe of HIV prevention, with NGOs being main actors. And the theories that we have in anthropology about stigma and a common understanding of stigma is also that stigma is about undervalued self, that this someone who carries stigma somehow undervalues themselves, and other people who look at them or interact with them also undervalue them as not normal or as someone who is lesser, right? So undervalue in that sense. And that's an anthropological theory would tell you, and here I'm referring to Eric Goffman, who is a famous sociologist. So the theory would tell you that the stigmatized individuals would often or always attempt to hide their stigma. They would try to pass as normal as much as possible. and not make their stigma visible to other people, even if they're stigmatized for their sexuality, for example, or for a disability, or for anything. If people are stigmatized, they would normally try to pass as normal and try to hide their stigma, or what is called stigma management. They would sometimes also engage in therapy to correct what is causing stigma, or their parents or their family or someone would try to somehow intervene therapeutically to get rid of the condition that is causing stigma. That is one form of stigma management. And then they would sometimes, the theory would tell you that people who are stigmatized would also sometimes retreat in the company of fellow stigmatized and not be seen or have to do anything with people who are stigmatizing them. So be in smaller groups with people who are like them. All of them might be collectively stigmatized, or they would try to pass as normal and conceal their stigma. So with this ethnography that I present in the paper, I have tried to give a different take on stigma, different conceptual take on stigma. And what is happening, as the paper shows, in the field of HIV prevention NGOs in Pakistan is that people are not trying to hide stigma in some cases, but they are actually, and they don't see as something that undervalues them, but they are using stigma in a very strategic kind of way to gain access to donor funding. And stigma, therefore, becomes not a negative attribute that one wants to avoid, or one wants to hide, or one wants to play down, or one wants to treat or cure, but it becomes a kind of a positive attribute at individual personal level for some individuals who try to, if you can put it very crudely, who try to capitalize upon the stigma that is attached to them or the people that they are representing as an NGO. So they try to play up that stigma, the difference from the normal. They try to play that up in order to get access to donor funding, or sometimes in order to legitimize themselves as a bridge between the donors, the state, and the people who are supposed to be beneficiaries of donors' interventions. So that is, I'm not passing value judgment there. I'm not saying whether they're doing a good thing or they're doing a bad thing, but that is something that comes up ethnographically, that people are using the stigma as a kind of a resource in some situations, which helps them get access to donor funding. Some of the individuals would use that for their own personal gain. Others would use that for the collective gain of the entire community. So in a way, they're turning something that is negative and bad into something that they can actually get something out of.
No, very well said. To be honest, as you mentioned, we have just seen it, war and tragedies like COVID pandemic is an opportunity for some people. No, so stigma is an opportunity for certain groups of people, unfortunately. Anyway, so I will ask Dr. Saima Abbas to continue now.
Okay, thank you so much. Bismillah. Thank you, Dr. Ayaz, for coming, and I so appreciate this. So I have a question. So you begin the article by drawing attention to the elephant in the room, which is criminalization of sex outside marriage, carnal intercourse outside the order of nature, which hints at homosexuality, and the non-therapeutic use of drugs. Three major behaviors which are criminalized. And not only in Pakistan, they're criminalized in a lot of countries around the world. So regardless of whether these behaviors will ever be accepted or decriminalized, the first step is to admit that these behaviors are continuing to rise. So overcoming denialism, which we have seen a lot in the last 2 years, is the first step. My question to you is that beyond denialism, criminalization of these behaviors has proved to be counterintuitive and paradoxically led to the continuation of these behaviors in hiding and further marginalization of these key populations. So does criminalizing these behaviors help anyone? And what can Pakistan do to address this, especially being a Muslim country with all the sensitive, religious, political situation that you have hinted at? How do you see this criminalization of behaviors? What role is it playing in stigma, and what is it truly serving?
Yeah, thank you very much for that question, Dr. Saima, and very aptly put. I think I don't use that phrase, but this is elephant in the room when it comes to policies around dealing with stigma and discrimination. So if we have that built into our larger political legal structures, how are we going to deal with it? I think yes, acceptance and countering the denialism that is there are very important steps. But in my view, this is something that needs to be addressed at the larger political, legal, juridical level as well. And to address that, I think we should do what social scientists call archaeology of knowledge power, using Foucauldian theory of power. So we need to go back into the roots of where does it come from? Why has it been criminalized? And if you look at that in the South Asian context, that also gives you, I think, gives you an understanding of where this criminalization has emerged, but also some hope of decriminalizing different sexualities and different behaviors. So where it comes from is the colonial law. I mean, we didn't have criminalization of different sexual behaviors or carnal intercourse before 1862. So we were very good Muslims back then as well, and we had different legal systems. We had different fiqh. We had different. Everything was there. I mean, it's not that we got legal structure only from our colonial masters in past 1 year. We had developed our own systems of statecrafts, of governance, of society, of legal systems and everything. But in those 1300 years, we didn't come up with criminalizing different sexualities, different genders, or different tribes in our penal code. But with the colonial rule, you have this criminalization of carnal intercourse, or what they called act against the laws of nature. So it's very Victorian in terms of its origin. It's not something that evolved post-independence. It is a continuation of the colonial law. So as we are undoing other colonial laws, maybe there is opportunity to address this colonial legacy as well and think more creatively about how in a Muslim society we can get rid of criminalization, which we did not institute ourselves, but was instituted by Victorian rulers of India. Yes, there are religious sensitivities there. There are political sensitivities there. And the fact that in the 80s, for example, the drive to Islamize Pakistani state and society through political action has led to consolidation of those laws, which were perhaps not taking the ground reality into consideration and were coming from a purely ideological viewpoint. And that have kind of cemented some of those colonial laws which are not helping the situation with HIV, for example, or other infectious diseases, which are not helping the situation with stigma and discrimination against certain sections of population. So with that kind of Islamization of the state and society, I think some of those legal, political superstructures, which were a legacy of a foreign rule, have been further entrenched. And the way forward for us as Muslims, as a Muslim society, as a Muslim country, I think, is to think beyond those legal provisions of how we can maybe legislate in a way where we accept what is happening and have a positive approach to dealing with problems of public health that emerge from people's sexual behavior rather than banning them altogether. I mean, that is turning turning a blind eye to, as we say, what is already happening on the ground. And as far as discrimination and stigma and societal attitudes go, it goes both ways, I think, that the legal superstructures at the larger macro political level, what you have translates into local people's understandings and attitudes. So if a change comes from the top, acceptance is gradually created at the level of society as well. It can be the other way around as well, that you have grassroots movements which come together around a certain issue and eventually they end up changing constitutional provisions or legal provisions. And that is something that we have seen in our neighboring country, in India, where they have actually legislated now against this article in Indian Penal Code. So we share the Penal Code, it's Section 377, which India and Pakistan inherited from the British, which criminalizes different sexualities. So they have managed to repeal it, and partially on the basis of grassroots movements from below, which came together partially because of the activism around HIV. So grassroots movement in India has led to repeal of that section and decriminalization of sex between same gender identified people. In Pakistan, we might not see that happening given the reality that we have, but that is, it is not total impossibility. We can start with taking small steps, at least accepting that there is different sexuality, there is a continuum, there are different sexual behaviors that need to be accepted, and then they do not necessarily need to be criminalized. They have been criminalized for 150 years. That does not mean that they have disappeared. So what is the point of criminalizing different sexualities and sexual behaviors? So it's not really working. So the point that I'm making there is maybe the NGOs have a responsibility beyond providing these donor handouts to communities. They need to also advocate for the communities. And one of the ways to advocate for the communities would be to at least help them get their legal rights as equal citizens who should not be harassed or held for their different sexuality or drug use behavior.
Yeah, I have to point out that you are talking to a very unique audience because we are all healthcare workers. So, we have taken the Hippocratic oath that we do not discriminate. So we treat criminals. And I'm sure everybody in this audience has at some point, treated people from jail. And because I deal with HIV, I have a large population of MSMs that I deal with. So the reason I thought it was so important to talk about this in the healthcare community, because, when you live in a Muslim country, you are quite cognizant of the stigma, which is there. But what I don't understand is that physicians who understand the dignity of life, we are basically, our goal is to decrease stigma in the physician community, because we cannot discriminate. If we are truly Muslim, if you want to put it at that, we have to treat whoever we have to. So that is one point where I feel, regardless of the criminal laws and the right and wrong about these behaviors, as far as every physician in this audience, I would hope that we can, overcome that, because, believe it or not, even in the USA, there is refusal to care for these patients. Doctors will completely refuse that they don't want to take care of HIV patients, whether it's for infection control reasons or whatever. But anyways, back to your point about the NGOs. So the NGOs claim that they belong to these key populations. And so, for example, you had mentioned the one NGO who was a recovered IV drug user. And then he went on and developed an NGO and is now serving those he can gain access to because he's one of them. So this concept of being one of them, and then you end up using or victimizing the ones you are claiming to help. This is a painful point that came through this article. So please elaborate a little bit on that.
Yeah, sure. Yeah, I think that is one part of his being, you know, being one of them. But there are other parts of his being as well. If you take what they call in sociology an intersectional view of individuals, that as individuals, we are morally very complex beings. And that goes for anthropologists, for doctors, for NGO workers, anyone in the society. So we are pulled in so many different directions. That's one way of looking at it. But we're also constituted by so many different experiences and influences. So not every doctor is same, regardless of having taken the same, what is it?
The Hippocratic Oath.
Yeah, regardless of having taken the same oath. So likewise, and same goes for anthropologists or researcher or anyone. So NGO actors that I am writing about here, that I worked with, yes, you could be one of them, but you could also be not one of them in many ways. That majority of them would be people who are on the street, but you are someone who had a privileged background. So that is intersectionality, where in that individual, it's not just drug use status or drug use history, but it's also the class you come from, education you have, connections you had in the past, and connections that you can make. Your general outlook on life can be very different from others. So in many ways, this particular NGO was doing wonderful work. They were doing great work. And I really stand in awe of that person that I'm writing about, the way he managed to bring this IV drug users population into focus, and how the programs were scaled up, and how when the World Bank program was rolled out, there was already this structure available through which they could actually hit the ground running and start work. So there is a lot that NGO did, but there are things that the NGO did which not everyone would approve of or would appreciate, I guess. And same goes with other NGOs, also smaller NGOs. So whether these are NGOs or individuals, I think it helps to have an intersectional lens to understand people's moral complexities, why they're doing what they're doing, and some of the actions are in certain situations are driven by certain motivations, and in other situations, the same person might come across completely different. And that has that has happened many times with me interacting with NGO leaders in HIV sector in Pakistan. And it is really heartbreaking sometimes when you admire someone so much as an activist, and you can see the amount of work that they have done selflessly. And then in an interview, you hear from them something that you think they shouldn't really be saying about a fellow NGO worker. But then if you step back from that situation, you understand that we are all humans at the end of the day. We're all morally complex individuals. Everyone has different situations that they find themselves in. And I don't know, I have taken it in a different direction, I guess, but yeah.
I completely agree with the moral complexity. Nobody's perfect. But as you had elaborated that they were not hiring or so-called taking the IV drug users off the street, giving employment, and then just explain that point where you say that whatever salaries they were making, they were asking them to invest into the land, or just clarify that part, because there seems to be like a moral conflict right there, regardless of the complexity. You know, they need to kind of just please explain that one point.
Yeah. No, I'll happily do that. So I mean, in terms of the details of what was happening, as I understood it, is that these injection drug users, let's use that term, are people who inject drugs. So they were enrolled with the NGO, and then they were sent to these rehabilitation or detoxification centers, where the NGO's approach was to make these individuals as useful in the society. When they go back, they should have some skill, right? So it was part of their imparting a skill on recovering injection drug user. And their idea of skill was to train them in gardening, right? And gardening they thought was useful because gardening would also help them on the path to recovery, working with nature, working with soil, and searching your own soul in the process, and not using drugs, and which is a brilliant idea, I think, very good, wonderful. And as part of that process, they acquired some farms which were attached, agricultural farms, which were attached to these rehabilitation centers, detoxification centers. And these guys would then get a patch of land on the farms, and they would work on that, and the produce would be then sold by the farm, and salaries were given to recovering injecting drug users. But those salaries would be deposited in safe accounts because these guys could not be trusted with money. If they got money, they might go and buy more drugs, and then they would be back to, they would relapse. So they could not be trusted with the money that they were earning on these forms. So the money stayed with the NGO. So if you, I mean, yes, you can't perhaps question intentions or rationale of the NGO's policy here. There is a very possibility on the ground that if you give that money to the recovering NGO, the recovering injecting drug users, they would go and perhaps they would use that money on getting drugs, and they would relapse in a way. But then at another level, if you look at the same situation, over a sustained period of time, you see that there is a pattern that they are kind of working, they're earning money that they're not really getting. The money stays with the NGO. NGO invests that money in different projects and makes money on top of that. And the NGO then accumulates more capital, which is starting with the hard work of this recovering injecting drug users, whose life does not really change much after many years of that farm labor. So where does that, if some of you might have read Marx in this, in this group, so the value that is generated by the labor of the drug users is converted into capital, that labor is converted into capital, and that capital stays with the NGO rather than going to the families of the recovering drug users or the laborers who are working on those farms. So that is something that I could not reconcile, and I wrote perhaps a bit too bitterly about that. Yeah.
Yeah, thank you. Well, your bitterness is well taken. And I think we understand, although I think there should be a follow-up on to see if things have changed. So I'm going to hand over back to Dr. Sheikh for more questions. So much.
Thank you. So on the same line, again, our goal is to see how the healthcare providers are discriminating against those marginalized populations. So back to the same topic, that in your article, you're writing that the stigma against these commercial sex workers, transgender people, injection drug users, and homosexual men manifests in their criminalization that we discussed about the penal code, and their exclusion from the preventative services, and their dehumanized humanizing treatment at the hands of the HIV treatment center staff. So what was your first-hand knowledge or observation about that kind of treatment they were seeing at these HIV treatment centers, which were supposed to provide non-discriminatory care?
Yeah. So I mean, since this was ethnographic field work, so as you know, ethnography involves being embedded in the field. So rather than going to individuals in the field to collect data through one-off interview or questionnaires, ethnographer use this technique which they call hanging out in the field, which is spending more time in the midst of the action where things are happening and being embedded in the field to sometimes quietly, silently observe, sometimes also participate in the activities that are happening on the scene. So we call it participant observation, a qualitative method of data collection, where you take detailed notes. So what I did to collect the information that you are indicating towards was through participant observation and interviews with some doctors. So I was based at National AIDS Control Programs in Islamabad and Ayaz. So I started there in, I think it was August 2010, I think. So, and next 18 months, I was with them working as a volunteer, internee, anthropologist, researcher, a general purpose person who was around to draw upon his labor to work on this project or that project. So I had many colleagues there who very kindly gave me a little desk and a chair. I went there every day from 9 to 5. I would sit there. I would go to the meetings. And many of these doctors, as you know, many of these colleagues at National AIDS Control Program were doctors. Some of them were not practicing. Some of them had practiced in the past. And some of them were on a sabbatical kind of thing from their practice. So I spent many days and months in that office, sharing office space with them, going to donors meetings with them, and sitting in these workshops that they conducted, going on awareness sessions that they conducted, and interacting with NGOs that came there. So many kind of activities there. And beyond that, there was initial kind of embedding in the field. So I mean, you can imagine being part of an office space where people are very open about talking about things that they're doing. So I, as a researcher, was not just there to spend the day and do day-to-day work, but also take notes of what was going on as a researcher. And my identity as a researcher was obviously disclosed to everyone. Everyone knew that I was there as a volunteer, not getting any salary, and was there primarily for my PhD fieldwork and research. But the amount of time that I spent there, people opened up gradually, and initially they would perhaps not talk very openly in front of me, but then everyone was talking as they would talk in my absence as well. In addition to that, I interviewed people in provincial AIDS control programs, people who were responsible for HIV treatment centers. I also visited HIV treatment centers and counseling centers and had interactions and interviews with individuals who were running those centers. And a couple of quotes in the article, I think one of the quote is, I don't remember now, there were various drafts I worked on, whether that quote is still there or not. One quote was directly from HIV treatment center in charge, who said that I can tell by looking at them whether they are clean or not. And if they're not clean, I'll send them to psychiatry. I mean, as you know, I have not taken that oath that Dr. Simon mentioned earlier, but I won't do that kind of thing. I can tell by looking at you whether you're clean or not, whether you're telling a lie. But for them, maybe the situation that they find themselves in, this is very normal, and this is perhaps not discriminatory even or stigmatizing, given the amount of discrimination and stigma that is present in those settings. They perhaps feel that this is not really a thing, which as a researcher, perhaps it comes on your radar, or if you're someone who works in more sensitive settings, you see this as problematic, but for them, this was kind of everyday.
Yeah, that's
Yeah.
unfortunate. The quote was there, by the way. The quote is there. That
Right.
you mentioned that by looking. That's unfortunate.
Mm.
And my next question is also again the continuity of the same one that is there any correlation between the educational level of a person and the stigma? Like if in Pakistan, the physicians are most educated or any society, if they cannot take overcome their biasness, then how we expect the general public to change their perceptions and the stigma?
Yeah, I think, I mean, my personal belief and as a researcher, my understanding is that education helps awareness. The more educated you are, the more aware you are likely to be. Now, the next step is whether you change your attitude on the basis of that awareness, or you don't change your attitude and practice on the basis of that awareness is a different question, I think. And there are, perhaps you are educated, you are also aware, because you're educated, you come across material, or you see things, or you know a bit more about things because of your education. You are aware, you also perhaps want to change your attitude, but then in practice, you can't do that because if you do, then you stand out as odd person in this whole world, a whole setting. So there are multiple, I think, restraints there. Perhaps if we think about an individual in a situation where they are seen to be discriminating or stigmatizing someone, and you don't expect them, or maybe they understand that they shouldn't be doing it, but if they are not doing it, then they are letting themselves down in the setting that they are in. There is a possibility, hypothetical. But I would also, I think, strongly argue that sometimes, especially in public health policy, we put too much faith in education and awareness, especially raising awareness, for example. Perhaps the problem lies there. Maybe many people are not aware. That is why they're stigmatizing or discriminating. But there are other structural factors, I think, that equally are important if we want to deal with a public health problem. It's not just, I mean, as you know very well, it's not just awareness raising, but also making resources available, also creating an environment where an individual can actually change their attitude and not be looked down upon by his colleagues, let's say, or not be let down by their employer if they change their attitude and if they're welcoming towards transgender people, for example, or injection drug users. Well, just imagine in a general hospital ward, if you are warm to transgender people as a male doctor, you might be a subject of all kinds of rumors. You're being nice, humane kind of individual, and you're doing what you're professionally supposed to do, but there would be people around you who might say, okay, you are one of them, there you go. So where does that take you? All that awareness that you have, all you have positive attitude, but the environment is not right. It does not let you accept difference. So that there is that, and there's also, and I'll go back to the point I was making earlier, I think, yes, to change societal attitudes, there is need for more awareness. There is need for creating safe havens, creating environment where people can be themselves and people can express themselves. But also, we also need to work at the macro level at changing those structural forces or structural factors like legislation, for example, like the state criminalizing its own citizens on the basis of their drug use behavior or their sexuality. So that kind of change, I think political change has to come from top to enable people in addition to, of course, education and awareness and enabling environment.
No, excellent response. I just have a question about the same we discussed about the how the stigma can be used. In your article, you mentioned that the stigma operates as a mechanism for social control and exploitation in the hands of the powerful, but also that the stigmatized people, stigmatized group of individuals, may use the stigma as strategically for their own gains, as we discussed. If you flip the coin, now can you elaborate how are those people using this as to their advantage?
Yeah, so you can look at it at multiple scales as I do in the article. So So you have the NGO bosses who operate at the national and international level as gatekeepers of the communities. So here, when you tell the government or the the international organizations that, look, if you want HIV prevention interventions with this group or that group, you call them transgendered people, you call them MSM, you can't do it yourself, you have to go through us. So when you do that as an NGO, international NGO or local NGO, national level NGO, when you try to bridge that, it can be seen in both ways. One, that you are being a very helpful bridge to reach a community which is hard to reach, right? Which is a very good thing. Maybe if those bridges were not there, if these big NGOs, national NGOs were not there, state won't care at all about some of these populations. The international organizations won't be able to work with anyone because the state actually criminalizes them, is not interested. HIV is not a big priority for them. There are other things. And on top of that, people are already marginalized and no one wants to, as states, you are under no compulsion, perhaps. There is no pressure, so you can easily avoid anything to do with HIV. So if international organizations want to work with these populations, so they have these national NGOs. So in a way, the role of national NGOs as a bridge is a very positive thing because they are a bridge, they are the gatekeepers. Through them, you can reach hard to reach populations. But if you look at the flip side of that, by consolidating them as brokers, as a bridge, they're also creating more distance between hard to reach populations and the state. So the hard to reach become even harder to reach because to reach them, you have to first negotiate with this national level organization or NGO, which has its own idiosyncrasies, our own demands, our own let's say, pursuits, our own interests that has to be looked into. And it is in their own interest to make them even harder to reach. So you can't work with IDUs unless you go through us first, that kind of thing. So in a way, the cultural difference, the stigma that is already there is being consolidated by the so-called gatekeepers themselves. That as if IDUs are not people, as if they are a different kind of community who cannot be reached by the state or by others if legislation was in place. So that is one thing. That's a macro scale, larger scale actors. But then you have minor actors also, the small scale actors, people living with HIV, for example, are people who identify themselves as members of one of the high-risk groups, let's say, who take on that identity as a sex worker, for example, or as MSM, take on that identity in order to get access to whatever limited handouts are available in the community. And one cannot blame them for that because they are actually doing the right thing. That if in a particular situation, if it helps to get something for yourself and your family in the circumstances that we all know, economic circumstances, if you can be a pretend sex worker in a workshop for half an hour and you get 1,000 or 1,500, that's well and good. So in a way, you take on a stigmatized identity in order to get access to whatever funding is available at a smaller scale, at a very small level. And then you can scale it up. There are individuals who are building their own empires out of this stigmatized identity of injecting drug users as sex workers by being the gatekeepers of the larger community. And there are these individuals who are sometimes momentarily taking on that identity and slipping in and out of that identity in order to get access to maybe treatment, to maybe medicine or handouts, or even a conference fee or TADA or lunch and tea, and even that kind of small things. So in that sense, I say in the article that they are strategically using a stigmatized identity, which is counterintuitive given what we understand about stigma, that you would like to stay away from stigma, you would like to hide it. But here they're presenting themselves. Yes, I'm a sex worker and I'm a genuine sex worker. So I am legitimately part of this workshop and I deserve that 2,000 that you are giving as participation fee. And in the article also, as you know, I also talk about this whole competition within NGOs about which NGO is bringing fake sex workers and which NGO is bringing genuine sex workers. So it becomes a kind of valued commodity then, that identity, that if you have that, you can cash it. That's a rude word to use, I think, cash it with donors or NGOs. But in practice, that is what is happening. And it's not wrong from my position. It is imagine in an ideal world, if people didn't have to do that, how wonderful that would be. You don't have to get access to some funding or some handouts or some medicine for opportunistic infections. You don't have to give testimonials. You don't have to take on stigmatized identity. You can just walk into a treatment center and get medicine.
Yeah, it's unfortunate truth in Pakistan, as you said, the big stigma is an opportunity for some people, and it's like exploitation at every level, unfortunately, But to solve the problem, we need to talk about it, and that's what we are doing today, to recognize the problems the physicians are creating for themselves, for their patients and the community, and the patient themselves. So anyway, I will give to Dr. Sam Abbas to continue the discussion. Thank you.
Yes. Okay. So we are wanting to wrap up in the next 5 minutes and then have the other speakers also comment. So I just have this question. So this was in 2010 and 2011. So this is 11 years or 12 years almost. Do you think if a follow-up was done to your findings, we would find some evolution in the transparency and strategies used by these NGOs, especially as one of the NGOs is now a primary recipient of Global Fund. So they have to be doing something right have things changed? If a follow-up was required, do you think this is a good research to follow up on? I mean, you're doing this already, but what do you think about that?
Yeah, I think that's this is an anthropological study, and obviously in the article I'm speaking with reference to some NGOs, but this is a widespread kind of trend, and this is not that it was happening just around that time. Has been happening, or that it happens only in Pakistan or in certain settings. I mean, the key arguments that I have from my project, one of the key arguments is also that there is nothing unique in the situation that I'm working on. It's not unique to HIV NGOs, and it is also not unique to NGOs. That happens in state bureaucracies as well. And it is not unique to Pakistan either. No state, no place has an ideal kind of Weberian bureaucracy, or no place has a civil society where you don't have NGOs who are kind of mix of going forward, but also pulling the society backward in some ways. So this is a long-term kind of picture, I think, that has been there for some time. So follow-up, I don't know. I mean, I wrote it for mainly academic audience. Some people picked up some of the themes, but the findings that are there are not really something that is startling. That is something that we can all identify with.
Now,
we all know that these things are happening around us. So what I have done as an anthropologist is bring that all together into a nice piece of writing and engage with a bit of theory on stigma. That's all. Apart from that, I mean, anyone who works in HIV sector in Pakistan is all too familiar with these things already happening, and including some of the actors also perhaps. So I don't think that study would be very helpful in that sense, because this does not bring to light anything
New.
that people do not know already. Yes, it is significant in the sense that it tries to understand stigma in a different way. It also significant in the way that it takes a longer kind of look and tries to, rather than repeating recommendations about more awareness and less discrimination, it talks about looking at larger structures of power, and advocates for intervening at the level of legal superstructure regarding the elephant in the room, that, as we said, that nobody talks about. So it draws attention towards that. But I mean, what I can say that maybe we can keep saying that through our different forums. We can keep repeating that, but this is not something that people did not know and came to know through my study. There's something my study goes into contributing is to, I think, amplify those voices which are talking in those terms. That if you want to deal with this public health problem, you have to treat people as equal citizens, as equal humans, and you have to do that not only in your clinic or everyday interaction, but also as citizens of the state, as equal individuals, regardless of their behavior, sexual behavior, drug use behavior. They should be respected by the state. Only then they would be respected by people around them as well. I think that's a larger point that I'm trying to make, and it's not unique. And about the mishandling of funds and all that, we're all too familiar of that as well. But within, and I don't know if I have that quote in the article. Again, I don't remember, but one of the CBO members points out corruption of a rival CBO to one of the donor organizations. And the donor says that, or don't talk about that, we know what is happening on the ground. So the sense that you get is that, be it donors, be it NGO workers, be it state officials, sometimes they are stuck in their roles to do their bit, regardless of what is it doing to the overall picture. So sometimes we are very, in our roles, myopic in not seeing the larger picture and just getting our job done, spend this money here, have that many partners there, conduct an awareness session over there, and we don't see the bigger picture, I think. I think the need for all of us is to rise above our own individual bits that we are doing to see what is it. And that is exactly, I think, what your group is doing by talking to different people.
Thank you so much. I will say, though, I was not aware. You said everybody already knows, but the way what you have observed at the grassroots level going on, we were not aware that this is how it was being manipulated, so to say. So that is an awareness for all physicians. I'll hand it back to Dr. Sheikh for, I think, the last question, and then we'll take it to our guests. Okay, thank you.
So, Dr. Qureshi, I have my last question is in continuity of your point that you make, that the donor knew about the corruption, unfortunately. And so my question is, are there any professional and ethical standards for NGOs that are obliged to abide by the international standards like in Pakistan? Are there funding agencies know about it? Looks like they know about it, there's a corruption, but who does accountability? Who's responsible to do it?
Yeah, I think the NGOs, I don't remember exactly the name of the protocol now, but the protocol was developed several years ago. Some of the audience, I think some of the participants of the meeting might know that, and I would be very thankful if they can share. There was this NGO protocol that came into being many years ago, perhaps a decade ago, maybe more, where the emphasis was on NGO code of conduct, and the emphasis was on on somehow stopping the brain drain from government departments and state institutions towards NGOs, because NGO employees tended to be better paid and all that. So all the people who were useful previously in government sector would then leave the government sector and would join the NGO sector because of, so there was, I think, a code of conduct that NGOs devised to counter that negative influence that they were having on governance structures in different countries that they operated. Regarding accountability, I think again the problem is that it's really hard when someone is in their job and is trying very hard to retain their job in an environment that we are in. So people try to minimize problems for themselves and carry out their job from day to day, rather than pointing out something that would reflect badly on their own situation. So in this case, I think if the job of that donor representative is to spend that money, they would be focused on spending that money. And in the state sector also, I had this very interesting expression that I heard from one of my colleagues at NSCP. At that time, they were negotiating about who should get what in the next round of Global Fund project that was coming. And there were those negotiations happening, and people were trying to, and people meaning different partners, NSCP, PACPs, and different organizations were trying to get maximum for themselves. And in the midst of all that push and pull of who would get what part of the money that we are proposing to get from the Global Fund, they were writing this proposal. I had a conversation with one of very senior colleagues, and he said to me, that was revealing. He said, Ayaz, look, what is important is that money should come to Pakistan. How we use it is the next step. But if we start fighting before even we have the money, then that closes all doors already. So let us focus, first of all, on getting this Global Fund grant. And after that, we will see who gets how much money. So, and he gave the example that 2 plus 2 is 4, 0 plus 4 is 4, as is 1 plus 1 plus 1 plus 1, that all equals 4. As policymakers, he said, our attention should be on the figure of the 4, not on how it gets divided further down. So that is what I see as a key to understanding how people approach accountability, distribution of resources within the country. People are really focused on getting the money in the country somehow. And then if someone siphons off greater share, that's all right. You're also getting something out of it, that kind of thing. That is the thinking. And that is how the powerful become even more powerful. And many of these donor employees are focused on getting their job done, which is to distribute this money and somehow enable NGOs to write those reports for upward consumption. So most of it actually goes in training people to write those reports. And I can go on with other examples of on that point. There was a CBO that I worked with, HIV positive people CBO, very small setup, very limited amount of money they had. And they were complaining that most of the money that they have goes on writing those reports, because you have to hire a consultant who can write the reports. So that is how resources get distributed. Is that not objectionable that you have, let's say, 100 rupees, and out of those 100 rupees, 75 go on hiring a consultant from outside the community who is educated and well-versed in the lingo of the donors and who would write shiny, glossy reports. And the rest of the 25 that is left, maybe 10, 20, 10, 15 goes to the MD of the CBO, and the rest of it is spent on the community. So I think one way of looking at it is that people are narrowly focused on getting their part of the job done and not create any problems which would put their funders or their partners in an embarrassing position. Sorry, that was a long answer to
Sure.
a technical
No, that's
question.
great answer. I appreciate it. So I will give back to Dr. Fiza Gilani, so then we can speak to our two other speakers. Thank you, Dr. Qureshi.
Thank you very much.
Okay, well, I think, thank you so much, Dr. Ayaz. That was brilliant. I'm going to welcome Dr. Khalda Zaki, who has been waiting. Thank you, Khalda. She is a professor of sociology at Michigan State University. She's a sociologist, demographer, who suggests new ways and an interdisciplinary approach to education and research. She believes that a deeper understanding of the social, cultural contexts of family and community are vital to improving the quality of healthcare services in Pakistan. Dr. Zaki is a member of APPNA-MERIT HIV Committee and has been supporting HIV awareness and education project since 2021. And I invite Dr. Zaki to comment on this topic. And what are the solutions, Khalda? That's what we want. So we've heard about the in-depth analysis of the problems. Please go ahead.
Okay. Thank you so much, Saima. I'm glad to be here again. Dr. Ayaz Qureshi, I enjoyed your presentation thoroughly. You've done an excellent job on a very sensitive topic. So I am someone who approaches the issues from the perspective of what next? How do we move forward? And in the socio-cultural context of Pakistan, how can we eliminate the barriers to improve the quality of services and the access of the communities? After saying that, I am a retired professor, but I am not a tired professor. And you have answered many important questions and issues that were raised in the panel so far. I'm still going to ask mine. So overall, the foreign funded NGOs have played crucial role in the socioeconomic development, health and education fields in Pakistan. Still, their operations have been considerably controversial. So at the core of the controversy have been the donor-recipient power dynamics, the relations of NGO that keep them dependent on these foreign resources. In such context, it complicates the dimension of accountability and governance for these NGOs as they go in between the governments and the donors and their communities. So as such, in your case, in HIV prevention, your research has demonstrated how the NGOs, their donors, have appropriated the stigma of the stigmatized in their own benefits. That is raising questions of trust, credibility, violation of individuals' rights and privacy, and obviously accountability and governance. Under such operations, the ultimate goal of reduction in stigma and extension of services, improving the quality and treatment, must be compromised as the pre-existing stigma is exacerbated. Now, the briefly summary that in all of this, the communities are perhaps negatively impacted also. And you have addressed some of those concerns as well. Anyways, considering the Pakistan's conservative social, cultural, religious settings with flaws in its legal systems, that creates barriers. I call that those barriers of all sorts between the communities and service providers, NGOs, and their donors, a gap. There is a gap between those, gap between communities and gap between policies. Then how the I take the view of, you emphasize that the top-down approach works and have an impact in the communities. I question that, and I say that we need to look at the bottoms-up approach at the same time. You doing the needs, I mean, we need to do the needs assessment of the communities and identify their barriers so that the service providers, the NGOs, and the communities, physicians can address those. So how do we bridge those gaps? What kind of strategies would you propose? The strategies in terms of achieving security of rights and justice, equity. So going beyond, how do we improve effectiveness of treatment, behavior, and reduction in stigma? How the private government medical institutions, the teaching institutions, the universities can be involved in these partnerships so that the awareness is increased and the operations are improved. How do you look at that? How do you approach, rather I would say, do you think on the basis of your experience that society is ready in general to discuss these matters, which are very sensitive, about the men having sex with men, sex workers going out and glamorizing at times their role in bringing the issues up? How, and transgenders, I just saw a little note in the question coming up in the question answer sessions that transgenders are a different entity. They're all human beings. So how the society is prepared in general to accept or open up to these discussions, considering all the barriers. Thank you so much. I'll be brief.
Thank you very much for asking those questions. I think, and you cut it straight to the heart of the matter, I think, with your comment that what is really important is to think about the ways in which we can move forward and overcome some of these barriers and hurdles that are there in our society. And as you frame it, one of them is the gaps in the provision by the state, which then are filled by private sector and NGOs, often with the help of international donors, which leads to, I mean, on the one hand, there is a positive that there was a gap which is being filled by philanthropic individuals, sometimes NGOs, through donors' money, and people are benefiting from the services that NGOs provide. But then it also creates kind of dependency on donors. And given that the donor landscape is very unpredictable, they have their own priorities, or they have their own constraints also. So the flow of funding is not always guaranteed and sustained. So there can be abrupt kind of gaps in that provision. So on the one hand, there is that insecurity and uncertainty, which is related to donor-funded projects. And as you know, we have seen the emergence and disappearance of NGOs following different priority areas of different donors. In anthropology, some of our colleagues have called them as Frankenstein's monsters, some NGOs which just go in a deep sleep mode and they then spring back when there is some money in flood relief or in HIV or whatever sector it is. But anyway, so there is, I think they are filling the gap, but that is not a sustainable, long-term, durable solution. That kind of NGOs which are backed by international donors. We have to, as a society, move away from donor dependence. One. Number two, when the NGOs step into those gaps which are left by the state, then the state also recedes and goes in the back seat because they can see that if EDI is doing that, why do I need to do that? If some NGO is providing services to injecting drug users or sex workers or MSM, then I can be, a state institutions can be in a comfortable position and take a back seat and not have to do anything with those issues because gap is already being filled by non-governmental provider from the third sector. So in a way, it has positive impact in terms of the delivery of services and for the health of the populations in the short term. But in the long term, it has a negative impact of invisibilizing certain populations vis-a-vis state and citizenship, and also perpetuating an unnatural donor dependence, which is insecure and uncertain in many ways. So as a society, I think we need to reflect on that and try to move away from that situation of donor dependence. And one of the ways we can do that is hold our governments accountable and try to I think, advocate or help the governments to build better structures for sustainable provision of services across the board. So that's, I think, and that's easy said and very hard done. Perhaps we need to work on both fronts, as you distinguished between the bottom up and top down. Yes, the bottom up is bandage kind of solutions that in a very acute situation, it really helps that there is someone, at least if the government is not there and its institutions are not capable, there's someone who can mobilize resources and do something for people in need. That's brilliant, that's wonderful. That's what societies have always done anyway in some way or other, without or with international donor funding. So that is there. So that is bottom up kind of thing, but top down is also important. So maybe we need to work on both fronts, try to bring in institutional changes at the larger level to make states accountable and to make states provide services, everyone across the board. And bottom-up approach would be, as you said, going to the communities, mobilizing them, organizing them, identifying their needs, making them work with people who have resources to come up with kind of grounds-up structures for provision of HIV prevention in this case. The other thing about the sensitive nature of our society that you mentioned, and how to go about sexual behaviors or sexual identities given very sensitive religious political environment that we have. I think I would reflect on that a little bit by stepping back from this. I think it's very well-founded proposition, assumption that we're all a conservative society. But then let's also try to step back and not shut down possibility of acceptance on the basis of that thinking that, oh, this is a conservative religious society. I think there are many people, many organizations, many individuals, many communities who are perhaps not ready for a sea change, but incremental changes, maybe we should work on them despite the fact that this is a conservative society. That should not stop us from trying to push agenda in certain ways which will help public health causes like HIV prevention. And when I say that, this is, I mean, in relation to men who have sex with men, for instance, our transgendered population. Obviously, we do not want to advocate from tomorrow gay pride rallies that is not something that is going to happen maybe in many, many, many years in Pakistan. But we can at least decriminalize sexual behavior so that people are not stopped randomly by a police officer on the assumption that they are homosexual and then prosecuted on the basis of that. So if we remove that kind of penal code, we are letting people be who they already are. And we are not trying to encourage them to come on the street and say that I am SMS, MSM, and I am drug users. So that's not the kind of activism that I want to identify with or promote. But decriminalizing, at least, people are already who they are in their private lives. Why should someone prosecute them for their private behavior? We can at least work towards advocating that kind of change within the society and from above as well.
Thank you so much, Dr. Ayaz. Well said.
Thank you.
Tolerance is a virtue, I would say. And so that is what, at the end of the day, may Allah grant us that. Okay, so I'm going to give the mic back to Fiza. And we have our last speaker, Dr. Mustafa Surti, who's been waiting. So thank you so much for that answer, Dr. Ayaz, and great question, Khalda.
Thank you. Thank you, Dr. Ayaz. Thank you.
Thank you, Dr. Abbas, Dr. Sheikh, Dr. Qureshi, and Dr. Zaki. Now I want to invite our next and last panelist of the day, Dr. Mustafa Surti, for his comment. And thank you, Dr. Surti, for listening to almost 90 minutes of our discussion. Dr. Mustafa Surti is a double board certified adult and geriatric psychiatrist, specializing in psychiatric conditions affecting older individuals. He is the Chief Medical Officer of Butler Hospital, Senior Vice President of Care New England, an Associate Professor of Psychiatry, and Associate Director of Geriatric Psychiatry Fellowship at the Alpert Medical School of Brown University. He was the recipient of the 2017 Robert J. Westlake MD Award for Physician Excellence. And in past, he has received many Dean's Excellence in Teaching Awards, all the way from 2010 to 2015 from the Alpert Medical School of Brown University. Dr. Mustafa Surti, please unmute yourself. Thank you.
Thank you, Fiza. I'll be very quick. Thank you, Dr. Qureshi, for the nice presentation. Article is very interesting. Not very surprising, though. Even though I've been out of Pakistan for almost 27 years, I really enjoyed reading it. I read it this morning and enjoyed this webinar too. But I'm looking at it from a different perspective, a little bit than everybody else. So if you look at the Western society, I'm trying to distinguish stigma and illegal. In my dictionary, in US or other Western countries, started these incidents, the IDU, drug use, homosexuality, sex workers, started with criminalization. Then it went to illegal activities. Then it became a diagnosis in psychiatry till 1960s, where homosexuality was a diagnosis. And now it is not a diagnosis. It's a normal phenomena here. So now it has some stigma, and even in this country at some level. So I think when we look at Pakistan, Pakistan is the first stage. It's not a stigma stage, it's a criminalization stage. All three categories which we identified in this, they all criminal activity as far as Pakistan is concerned, with some punishment for any of that. So I think we have to start thinking from a different perspective first for the NGOs. I think you identified that there should be some NGOs who need to work on it from a different perspective. That doesn't stop us from helping different high-risk population. And it should be an open help with some, it's almost like, you wrote in your article about a place where where people are being helped, but it was kind of hidden behind the bungalows in a very affluent neighborhood, not a lower class neighborhood. So all those are important because it's still an illegal activity. So if you don't have a power or influence in Pakistan, whether it's money or political power, it's very difficult to do all these activities there because somebody will identify and you can be charged for it. It's all as, so I think we have to distinguish between stigma, legal issues, tolerance, which is a big issue, which I think goes with it. One is you're not accepting the high risk population, whether it's a religious reason, cultural reasons, or your own belief system. But tolerance is the first step to identify, to get help to them. If you not have, which we lack in Pakistan, unfortunately. If tolerance is not there, then we have difficulty helping anybody out. And then I think you're right. Some NGOs, I would not say all, do take advantage of the situation because they are working as a conduit to the government, because the government doesn't want to identify as an entity themselves trying to help the high risk population, because in their constitution, in Pakistan constitution, it's not a legal activity. So they cannot legally help them. It has to go through a conduit. So somebody takes advantage of the whole situation, which could be some NGOs. I'm not saying all of them. I'm sure there are plus and minuses. So I try to look at the glass at half full rather than half empty. I do want to specify on the drug use programs, which I do some of it here. The comment about a doctor looking at the patient and saying, I can say he's using drugs or not, I think that's a pretty blunt statement. But in some cases, that's a reality. You can see somebody's pupils and all that and identify that they've been using something actively. That kind of stops us from treating them with medication, substitution therapy. Because if we give them those medicines, they will have a significant reaction. So they need to go to a physician to get help medically first, identify what they were using, which can be urine test or whatever, blood test, identify what they were using. So the next step is all medical first to help them out, medically detox them. The programs about farms and all that, it's a holistic approach, which is used even in US at some level. In fact, those programs are very expensive and private pay here, not covered by the insurances. But people do go to these programs, even in this country, with no medication. And there is some success in that, not in all of them. But again, the goal is, our question is, what is the goal behind it? Is it to help the patient or is it to make money from it? And people take advantage here too. And people take advantage, I'm sure, over there too, because there is no check and balances on this and there is no quantitative data. The financial thing happens in this country too. If we have patients who are in the substance or have some psychiatric condition, they cannot manage their money, and they have shown multiple times over the course of a year that they are not able to manage it, the court gets involved and identifies somebody as a direct payee who basically takes the money and gives them on a weekly basis or daily basis or even pays the rent of the apartment. I'm not saying what's happening in Pakistan is right or wrong. It's more about how we enforce it, and there's some accountability of that. Because these are not bad ideas about substance use treatment or whether with medication management or social factors or holistic approach. You just have to make sure you enforce it properly. I'm not sure how to do it. I think there has to be one thing that somebody raised, which maybe you can help since you spent 2 years there. What is the role of the international donors who are giving money to NGOs? And I know the government cannot control it. They might have connections with them, but the international donors need to have some idea about it. Or they collaborate with some private hospitals to help it out in some cases. I don't know if government cannot do it, because legally, I think they cannot do it. Academic centers and hospitals is a brilliant idea. But if it is counted as an illegal activity in Pakistan, I don't know how they can justify it.
No, thank you. Thank you very much for all those points. And broadly, we are in agreement on the importance of tolerance or acceptance of different sexualities and different kinds of behaviors, obviously, and that is a key. If you're looking at it, as Dr. Khalida said, if you're looking at it from bottoms up kind of thing, tolerance is the key. If you're looking at it from top down, then as you said, the criminalization is the key, that decriminalization is something that will come from above. I can't just stand somewhere and say that from today this is decriminalized. That has to come from the state. And I think both those things are really important, that we build this change in attitudes bottom up, creating more tolerance and acceptance, and also working on those top-down decriminalization of different behaviors. So that is really important. I totally agree with that. In terms of the ability to see whether a drug user is clean or not, I don't know if you use the term clean in US, but it might have come from there actually. So what if I think the point here is that not doubting that there would be some physical symptoms that the physician can see, other people cannot see about the drug use. But here, the way that was used was, I mean, the way that was expressed was problematic, and also then followed it up with the suggestion that if they have a doubt, then they would send the patient who presents themselves to the psychiatry department to determine whether what they were saying was true or not true, whether they were lying or they were being truthful about their clean status. So that is, I think, problematic in some ways, and is perhaps not based only on the fact that someone has expertise, but also it has that stigma built into that kind of behavior, I think. And in terms of the whether we put them on medication or not, I think the WHO guideline has been that whether injection drug users are currently active or not, regardless of that, they should be provided oral substitution therapy. That was a guideline at that time. I mean, it would vary. I mean, you know better, obviously. It would vary from case to case, perhaps, to what extent they have been off those non-therapeutic drugs and how you manage people from case to case. But here, what they were doing was keeping this kind of uniform policy that only those injecting drug users are clean who come through the NGO, because NGO makes sure that they bring clean IDUs. Whereas if someone presents themselves and says that they are clean, then the doctors would turn them away, saying that come with that NGO guy, only them we trust, we don't trust you, which is again stereotyping the trustworthiness or untrustworthiness of people who use drugs, which is a big stigmatizing stereotype, obviously. I mean, it is not totally impossible to imagine that someone goes on their own and says that, well, I'm HIV positive, I have been off drugs, so give me ARVs that I need. I'm no longer with the NGO, but they would be turned away. So those are, I think, problematic instances. In terms of also the management, rehabilitation centers, where you yourself mentioned that there are procedures in place, and it varies from case to case. There are court cases, who the people would be, who will manage the finances, and cases would be perhaps looked at in some detail while taking those decisions from case to case basis. Here, they had a uniform policy that once you're here, you don't get that money, we get that money, we keep that money, and we know how best to use that money. You only work on the form. That is perhaps not fair to those who might not relapse. I mean, who might be more trustworthy in terms of their own financial management. So having that uniform policy does not really help in those situations, I think. Well, I mean, this is a discussion that we can carry on for much longer. But thank you very much for raising those points. Yeah.
Thank you so much, Dr. Stigma. I think we'll have a separate psychiatric session on stigma, which is much needed. But I have a hand up. I think Dr. Asma Naseem either had a question or a comment. Dr. Asma, are you here?
Saima, I just want to add, Ms. Muswa and Ayaz, very really worthy discussion. And I think hopefully in future we will do this again, purely on psychiatric point of view. So I will ask Asma if she is there. Otherwise, Bushra, if you want to comment from Pakistan side. Dr. Asma Naseem, if you are still there and you have raised hand, please unmute yourself. It's still there. So,
Oh, hello.
yes, Asma, आप बोल सकते बात कर सकती हैं.
Ji, Assalamu alaikum. Yeah, so thank you very much for allowing me to speak. Dr. Ayaz article I read it was very, very interesting, really, and an eye opener. But what I observe or I felt that basically it's all about money. Here, a lot of people, lot of NGOs, they just operate just for money, and everything moves around getting donations and something. Second, very important, it's just a comment. And second thing, very important point which Dr. Ayaz mentioned was the decriminalization, which is really very, very important. And an interesting thing about everybody is putting people under the umbrella of MSM, which is also very, very interesting thing to read that, yes. And an eye opener for me, because I am a doctor myself, and I sit in a tertiary care hospital where a lot of I saw a lot of very sick HIV patients, and we definitely we too put these people in small boxes. This is IDU, this is MSM, and which is really very sad, really. And thank you very much, Dr. Qureshi. You did a very good job, and I think we need a lot of articles on these issues. So it's just a comment. Thank you.
Thank you, Asma. And that is what actually I always say, that please encourage your students to do PhDs on HIV topics. We already have, I think, 1 or 2 very recent PhDs, so we'll encourage more. So we can have more Dr. Ayaz Qureshi in our future generations too. So Dr. Busha Jamil, I would like if you can comment from Pakistan side too. And thanks, Asma, for
Yes. Thank you very much. This was indeed a very different webinar and very interesting one as well. So we are very unfortunate that the entire HIV program is donor funded, and the government has so far not set aside any budget to address any of the HIV related issues. So if Global Fund decides to withdraw their funding, we will be left with nothing. So that is one very precarious situation. So luckily the Global Fund has not decided that yet and continues to fund us. The second thing regarding CBOs is that it seems like as if CBOs have held the donor hostage, because the donor has to go through certain procedures, and that it cannot do if there is no structure to the agency which is going to dispense the funds and perform the activities. So what the Global Fund does is give us a list of requirements, and there is some degree of monitoring attached to it as well. So the CBOs or the PR or SR who show results for the funds they are getting, they are the ones who are likely to get funds in the next cycle as well. So there are certain key performance indicators which everyone has to fill in and achieve a certain target. So it's not that people are just given funds and no questions asked. It's not like that. So NGOs which are doing well and continue to enjoy Global Fund year after year are the ones which are actually delivering, if not optimally, in some areas. And Dr. Ayaz's paper is amazing. His observations are on the spot because I spent 1 year, less than a year in Islamabad, looking at various aspects of the AIDS control program, and I totally agree with his observations, but there are these additional points that they have to show performance. Sometimes there are NGOs which do not show performance, but they are in some way useful to one agency or another. So they do get a small pot of funds, but greater portion of fund generally goes to an agency which shows results.
Thank you, Bushra. Thank you so much for your expertise, as always. Hanji Fiza, are we ready to wrap up? Okay, last question, Dr. Ayaz, what do you think about our World's AIDS Day report? And did you get a chance to look at the Build Capacity project that we had mentioned?
Yes, I think I read the report, and thank you very much for sharing that report with me. I think it's brilliant. It's very good. I mean, the way you have identified the gaps and the approach that you're taking towards those gaps and practical steps that you're suggesting to help the situation by building capacity at different levels, using your expertise as a group and using knowledge exchange and sharing of best practices. I think it's really important. It's really important. It can go a long way, I think. But again, I was just thinking to myself, it does need that environment in which these things can be done. That receptive partners out there, I think, is a key to the success of the plan that you have in that report. Thank you for sharing that. It was really good to read for my own awareness as well.
Okay, well, thank you for being here. And we have had, I think, more than 40 participants. So, you know, the journey of 1,000 miles start with one step. So we started in 2021, and inshallah, you know, we get to a point and a door opens, and then we get to the next point and another door opens. And you were one of those doors. Actually, my brother shared this article with me. So I'm so happy that we went along with it and talked about a subject that needs to be talked about. So completely appreciate and thank you, Khalida. And I must say, Khalida was the one who actually gave us the framework of the gaps, the knowledge, the attitude, and the practice gaps. And then I just loved that idea. Yes, thank you, Khalida. So it's like a jigsaw puzzle. Hopefully it's coming together. But you're right, you know, anything we say from here, I think Dr. Bushra understands that she is actually, you know, and all of the physicians, they are on the front lines.
Yeah.
We are trying to support and talk about these issues, and hopefully some action will also take place. So,
yeah, and I think we should appreciate from afar that people who are on the ground have their own limitations as well, and we need to work around those sometimes and not raise our expectations too much. But I'm sure Dr. Bushra is doing wonderful work on the ground. Yeah. Well, thank you, Dr. Saima, Dr. Fiza, Dr. Khalida, and Dr. Mustafa for your very kind comments and for engaging with the paper.
Thank you. Thank you very much for coming to us.
Thank you.
Very nice meeting you,
Yusuf.
Dr. Ayaz Qureshi.
Yeah.
And thank you, everyone. Bye-bye.
Thank you.
Bye-bye.
Bye. Hafiz.
Assalamu alaikum.